Welcome to ATCM Emergency Medicine Channel. I'm Dr. Arya from ENT, first year postgraduate. This is my associate professor, Dr. Janvi from ENT as well. So today we'll be presenting a case of acute sinusitis. Yes, ma'am. So we had a case in the ER recently, one 23-year-old female patient who's a non-case of bronchial asthma, came with complaints of postnasal discharge and also headache since the last four days. So initially she had the similar complaints in the first week of this month, and then she was better, and then later on after a few days she again started having these complaints. So she was having postnasal discharge and she always could feel that phlegm in her throat, and then it was causing her some cough. And she was also on Formaflow, 250 mg syrup, that puff inhaler was also used. And she was using nasal sprays, but then recently she stopped using it. She's using it only whenever she's having some issues, so any allergic bouts or anything like that. So as of now, she was not complaining of any breathlessness. She was just complaining of cough, fever, and then that postnasal discharge. And there's a little bit of nasal discharge as well. So on examination, I could find that she had a DNS to write with inferior turbinate hypertrophy, and then I couldn't find any active nasal discharge. And then posterior pharyngeal wall, I could find that the patient had follicular posterior pharyngeal wall. And
Congested
and follicular. But then the tonsils were bilaterally grade 1 and not congested at all. There were no significant cervical lymphadenopathy, nothing of that sort. Then no other issues now. That's it. And she also had frontal tenderness of the right side, frontal tenderness, and right side maxillary tenderness as well.
She was complaining of specifically right-sided headache?
Yes, ma'am. Specifically to the right side, and its entire face, the face was hurting for her.
So there was facial pain?
Facial pain was there. There was no ethmoid sinus tenderness was not there. So that was a case that we got in the ER recently. So we managed her by giving her an immediate shot of paracetamol for the pain. She got better after taking the paracetamol. She was doing nasal wash, so I advised her to continue doing the nasal wash. And then
How had she started nasal wash on her own already? She was known to have any sinus disease previously?
She was previously admitted under pulmonology for acute exacerbation of asthma. At that time we had done an NPL for her, and then in that we found just nasal discharge, bilateral nasal discharge, that's it. So we started her on a nasal wash back then, and we had asked her to continue it whenever she feels difficulty. So she had been using it, so she knows how to use it. So she is willing to use it again. So I suggested the same.
How did she come to casualty with these symptoms? She could have come to the OPD in the daytime.
Yes,
was
ma'am.
it that bad?
It
the
was
headache?
the fever. She was having
So the pain was that bad?
Pain and the fever was very bad.
As is, usually you don't expect these patients to come directly to casualty.
Yes.
Unless it's that bad.
Unless it's bad.
And she had high fever?
Very high fever. Not too high actually. It was 99.
99. Okay.
Then she was finding it very difficult to walk around. Like the headache, whenever she was bending down a bit, the head was hurting very badly. And on a pain scale, she gave a 10 on 10.
Okay. All right. So did you do any imaging further, and did you do blood tests? A complete blood count was done?
We did a point of care CBC for
Okay.
her, which didn't show any particularly elevated CRP or any of that. WBC was not too high. It was around 11.6. But then previously we had done an X-ray PNS Waters view, which didn't have particularly any findings.
Okay.
So
no particular sinus was showing opacification?
Yes, ma'am.
Okay. So in this kind of case, how would you manage this patient further?
If it is a case that comes as an acute case, like within less than 10 days of history, we would treat it as a viral rhinosinusitis case.
Viral or bacterial? Viral or bacterial acute sinusitis.
So we can start her with nasal decongestants, nasal douching, and something for the pain, paracetamol or something like that. And then if the discharge is colored like green color sputum or yellow color sputum, then we can start her on some antibiotics as well. For a 5-day course of antibiotics, and then we
so usually a course of amoxiclav, anti-inflammatory, and since the paracetamol worked for her, which means that anti-inflammatory should work further. So a course of antibiotic, along with that anti-inflammatory, along with that sinus rinse. That's one of the most important things, which she was already doing. the nasal wash. And it is preferred to make sure that you do a nasal endoscopy, even though the patient had a nasal endoscopy previously during admission, but these are new symptoms.
Okay.
Because being new onset symptoms, it's always preferable to repeat an endoscopy for the patient and see if there's any active purulent discharge. Do you see any other findings in the patient's middle meatus?
Okay.
And treat accordingly, if anything further. Other than that, what you should actually be aware of while practicing in the ER is one of the most important things to take home for y'all. Because in the ER, if you have a patient with sinusitis, along with conjunctival congestion or developing chemosis, blurring of vision, okay, any sort of visual disturbances if they're saying, then these are all alert signs. Okay, any new onset diplopia along with the headache. Okay, and usually you don't get a patient with acute sinusitis and any CSF leak, but if for intracranial extension, this would be the main things to look at. One would be intractable headache, not getting better with medicines, that is not getting better with paracetamol or any other anti-inflammatory. Then second would be eye signs. So redness of the eye, swelling around the eye, any periorbital swelling, diplopia. Okay, so visual disturbances. Those are the main things to look at. Then if the patient is developing any neurological disturbances, any third nerve involvement, sixth nerve involvement, then you should be aware to look at any possibility of a invasive fungal sinus involvement. That's the main thing, because being in the ER, that's why I was asking, why did the patient come to the ER directly? Because usually you don't expect an immunocompetent patient with just headache and nose block to end up in the ER in the daytime. So that's how probably bad her headache was. But the good thing is it got relieved with paracetamol. So that was sufficient. So these warning signs are the main things that you should be looking for. And yes, doing a nasal endoscopy is absolutely important for this patient, because just the other day we had a lady with severe headache whose MRI was, of course she was immunocompromised. Her HbA1c was 9 point something and she was admitted under geriatrics. She had headache. That was her only symptom at that time. When we did an endoscopy, she had a discolored right middle turbinate. So it was becoming slightly greyish. So what we did was we asked for an MRI with contrast for her, and it was showing non-enhancement of the right middle turbinate, which was indicating an invasive fungal sinusitis. So when we took a biopsy for her from the sinuses, that grew rhizopus. So those are the things. Maybe sometimes the only presentation in an immunocompromised patient would be a headache. But we have to know which patient to investigate further. And that's the importance of a diagnostic nasal endoscopy.
Okay. So in case a patient comes to the ER with orbital cellulitis kind of features, ma'am, what would be the primary approach? How will we approach the patient?
So one would be again to do a nasal endoscopy and see whether there's any purulent nasal discharge. Is it like a bacterial associated orbital cellulitis, which is common in patients with immunocompromise. So diabetic patients, patients with CLD, any hematological malignancies, those kind of patients usually have a chance of going into orbital cellulitis. What we see most commonly is as a complication of either really bad acute bacterial sinusitis in immunocompromised patients or an invasive fungal sinusitis with orbital cellulitis. That is usually when we see these kind of patients. And if it's only a preseptal cellulitis, usually it settles with the course of antibiotic or antifungal, depending on the organism.
So, preseptal cellulitis, is it an indication for surgery in these patients?
If the sinuses are significantly involved and it is not getting better and the patient is immunocompromised in a way that the infection will not heal well itself and you need to surgically open the drainage of the sinuses, then yes, it is an indicator for surgical intervention. Saying that, at the same time, when you have an acute sinusitis patient, you don't usually, it is actually a contraindication to endoscopic sinus surgery. But if there is no other way, it's not draining, the patient is immunocompromised, you know the healing is not going to be quick, the patient is not going to be able to recover quickly, you have to open the sinus if it's going for orbital complications. And if it is fungus, then there is no doubt that you need surgical debridement.
In the ER, how can they distinguish if it's a fungal sinusitis?
The only way is imaging. That's all. Otherwise, direct examination, unless the mucor has spread so much all over to the septum that the septal mucosa, the inferior turbinate mucosa has also developed that black eschar. That's the sign you call black eschar, the blackish discoloration of the mucosa. Unless that is extended to the mucosa of the entire nasal cavity, you won't be able to make out on direct examination that it's a fungus case.
So there is a healthy suspicion for any patients coming with an eschar in the nose or also in the skin can
No, eschar is something that will develop much later.
later. Okay.
It won't develop very early.
We initially had
In fact, we have so many patients whose nasal endoscopy is normal, but the scan is showing disease in posterior ethmoidal cells, only within the cells. So we have to literally open those cells during surgery, get to the disease cell and take biopsy from there to prove that it is a fungal sinusitis. But the patient is actually having headache and orbital involvement because of that fungal sinusitis, because it has started eroding the medial wall of the orbit. That's the thing.
Okay.
Okay? So I think you all are clear with the possible signs that you should look, warning signs that you should look out for.
Yes, ma'am.
Right?
Yes.
Okay. Thank you.
I think that would be it. Thank you.